Hi, thanks for joining us. My name is Jack Reichick, and I'm a pediatric cardiologist at the Children's Hospital of Philadelphia. Welcome to Pediatric and Congenital Heart Talks, a series of lecture presentations and discussions on interesting and important topics in our field of pediatric and congenital heart care. In this series, we will share insights on a variety of topics, offer new perspectives on some basic principles, introduce novel concepts and innovations, as well as identify what needs to come next to solve challenging problems in our field. Our objectives are to provide education on a variety of topics, but also perhaps to stimulate some provocative thought on your part. We'd love to hear from you and to get your questions and thoughts on these discussions. You can contact us at this email address, chophearttalks@email.chop.edu. Okay, let's go ahead and get started.
I'm Jonathan Chen. I'm the Division Chief of Cardiothoracic Surgery at the Children's Hospital of Philadelphia. I'd like to welcome you back to Pediatric and Congenital Heart Talks. You know, pediatric cardiac surgery has come a long way since the 1950s when the titans of cardiac surgery tackled and successfully moved the field forward beyond cardiopulmonary bypass and closing simple heart defects to where nowadays we operate on newborns pretty routinely. And although mortality and outcome as an outcome measure is not the only thing that we study, and it certainly is not completely in the rearview mirror, many of the other serious morbidities that happen perioperatively remain major challenges for us. And possibly the most devastating of these are neurological problems that can happen after open heart surgery. Nothing is probably more devastating to hear from parents than that their baby has had a seizure, and hard also to contextualize what exactly it means if it's a so-called subclinical seizure, meaning it's something that's on an EEG but is not being manifest clinically. We are fortunate here to have a very strong cardiac and neurologic teams who are interested in this problem. Among them, I have the great pleasure to introduce Naim, who is an assistant professor in the Division of Anesthesia and Critical Care, who has dedicated her career toward the area of resuscitation and neurological outcomes in congenital heart disease. Naim today will be speaking to us and reviewing how can we protect against injury and stressors in the perioperative and intensive care arenas. Naim.
Thank you very much. Today's topic is definitely very close to my heart. I think just as Jonathan alluded to, very often children make it through the ICU, and what we really want to see them doing years and years from now is surviving and thriving. So we want normal kids just like our own kids. So today what I'm going to be talking to you a little bit about is identifying some of the physiologic stressors in the perioperative arena in neonates. We're going to talk about some of the strategies to identify brain injury and stressors in the cardiac intensive care unit. And then I hope by the end of this, you'll be able to have a good understanding on how to analyze existing data regarding the impact of seizures and outcome. So what are the perioperative stressors? So what we do know from great work at CHOP and other centers is that babies with congenital heart disease are actually born with abnormal brains. They are born with brains that are immature, and this probably makes them very susceptible to perioperative brain injury. In the preoperative phase, perioperative brain injury has been associated with children having a postnatal diagnosis, severe hypoxemia following birth, such as in babies with transposition of the great arteries, and then also an association with balloon atrial septostomy, which has been hard to tease out. As at CHOP, we looked at this and found that it was more the timing of surgery in babies with transposition of the great arteries and not as much hypoxemia that determined postoperative brain injury. Other stressors are those that occur in the operating room, such as deep hypothermic circulatory arrest. Antegrade cerebral perfusion was developed as a strategy to prevent brain injury and seizures in this population. However, as I'll show you in a little while, we see it in both DHCA and in strategies and operations that use antegrade cerebral perfusion. A low hematocrit during bypass has been associated with postoperative brain injury as well as hypotension in the OR. And in the postoperative field, which is where I work, we see low cardiac output, hypotension, hypoxemia, cardiac arrest, and ECMO all being associated with brain injury. We don't always have a chance to intervene. So some of these factors are non-modifiable factors, but where we have a chance to intervene is in the timing of surgery in our patients, as well as the prevention of cardiopulmonary deterioration, at least postoperatively, and in the identification of brain injury. So the gold standard for identification of brain injury in neonates is a brain MRI, but this is not always feasible. So the approach that we've had at CHOP is to stratify MRI based on neuromonitoring. So what about neuromonitoring devices? The most commonly used device in clinical practice currently is near-infrared spectroscopy. A device like this and other ideal neuromonitoring devices should be readily available, reliable, non-invasive, easy to interpret, and cost-effective. They should be able to correlate with brain injury, and ideally also correlate with long-term outcomes. However, there's very, very little data associating monitoring and imaging with outcome. The continuous neuromonitoring device that we're currently using at CHOP is a continuous EEG, and this is something that we've been using for a while, and more recently we've also started using near-infrared spectroscopy. While near-infrared spectroscopy is an excellent way of monitoring patients intra and post-operatively, it can sometimes not be very sensitive and specific. So for example, over here you see this is a squash, and the nears on this vegetable are probably where I want my nears to be, so 60% on each side. So as you can see, it's not a very sensitive and specific device, but still very, very helpful in clinical practice. So where and why did we start monitoring neonates with congenital heart disease with EEG, and why did we do this? So in 2011, there was a landmark study that came out, and this was the 16-year outcomes from the Boston circulatory arrest study. And although many of these children were doing very, very well overall, they had lower academic achievement, memory, executive function, visual spatial skills, and attention less than the normative population. And the medical variable that was most consistently associated with worse outcomes was postoperative seizures. Many institutions have published their experience with neuromonitoring with EEG, and one of the big questions out there was, is it because of the use of deep hypothermic circulatory arrest that children have post-op seizures? However, as you can see, and what I really want to highlight over here is that the majority of seizures in neonates with cardiac disease are subclinical, and they do occur after surgery with deep hypothermic circulatory arrest and with antegrade cerebral perfusion. Because of these reasons, the American Clinical Neurophysiology Society has recommended routine continuous electroencephalography in neonates, and very specifically with cardiac disease. And this is not only postoperative neonates, but also neonates that have a cardiac arrest or end up on ECMO. So after this landmark paper in 2011, we started monitoring patients with routine EEG, and I will say that our goal, as I've mentioned previously, is really to optimize neurodevelopmental outcomes in our patients. Of note, in the Boston circulatory arrest, 20% of patients had seizures. Of those, only 6% were clinical, so the majority of them were subclinical, and the subclinical seizures did not get treated, so no anti-epileptic drugs were given to these patients. So a little bit about our experience between 2012 and 2015. During that time, 386 neonates were monitored with EEG. The way we set this up is that there's a machine at the bedside. Patients are on EEG for 2 days, for a total of 48 hours. And then the bedside clinical staff is able to push a button when the patients have an event that looks like it may be a seizure. 22% of these babies had push-button events. However, none of these correlated with seizures. About 8% had postoperative seizures, and seizures started at a median of 29 hours postoperatively, and were EEG only in the majority. And there was a very high seizure burden, with almost half of these babies having what we call status epilepticus, or really prolonged seizures. In terms of outcomes, we found that the median CICU length of stay was longer in neonates who had seizures compared to those without. The median hospital length of stay was also longer. And the mortality was higher in the neonates who had seizures, so 26% versus 6% in the neonates that did not have seizures. So seizures were associated with outcomes. And what I want you to be thinking about right now was, is it actually the seizures or is it brain injury? So as I said, seizures were associated with short-term outcomes. In terms of seizure predictors on univariable analysis, a lower gestational age, delayed sternal closure, deep hypothermic circulatory arrest duration. Of note, in this era at our center, we were only using deep hypothermic circulatory arrest and not antegrade cerebral perfusion. Cardiopulmonary bypass duration, ECMO in the OR, and cardiac arrest in the OR were all associations. And on multivariable analysis, a gestational age less than 38 weeks and cardiopulmonary bypass duration greater than 60 minutes were associated with seizures. We treated seizures with phenobarbital, which is one of the classic drugs used to treat seizures. However, we did see that some of these patients were having side effects like hypotension. And over the last couple of years, the drug Keppra has come into use. And so we started using Keppra as an alternative to phenobarbital, as it has a better hemodynamic profile. What you can see in this graph is our experience with using these two medications, which were both similarly effective in treating seizures. So neither one completely eliminated seizures, and almost half of patients started on either the phenobarbital or Keppra were refractory to therapy and had to be given a second-line drug. And as I said, more side effects were seen with phenobarbital therapy. So the million-dollar question is, does EEG monitoring change outcome? So in this study, which was an in vivo study using NMR spectroscopy, babies, 8 infants with seizures were studied. And during the study, 4 of these babies had seizures that caused a 50% decrease in the phosphocreatinine and to inorganic phosphate ratio. What this suggests is that there was increased cerebral energy utilization during neonatal seizures. One patient's seizures was successfully treated with intravenously administered phenobarbital during this study, causing an immediate increase in the ratio, suggesting that with treatment of seizures, the cerebral energy utilization returned back to normal. So neonatal seizures may be causing or exacerbating cerebral injury by increasing cerebral metabolic demands above the energy supply. There are some short-term clinical data to also support this. In a study from Toronto, looking at children monitored in the PICU and the CICU, who had indications to monitor indications for seizure monitoring postoperatively, 36% of these patients had EEG seizures, and 9% had electrographic status epilepticus. And the majority of these, as I mentioned, were subclinical seizures. And increasing seizure burden was independently associated with neurological decline at a hospital discharge, even after adjusting for diagnosis and illness severity. What you can see in this graph is that the odds of a worsening PCPC, which is a pediatric cerebral performance category, was 387 times higher in children who had an increase in maximum hourly seizure burden of 50%, really indicating that increasing seizure burden is associated with worse outcomes independently at discharge. What about long-term outcomes? So as I mentioned, in the Boston circulatory arrest study, the majority of seizures were subclinical, and subclinical seizures were not treated with anti-epileptic therapy, as the investigators had blinded the clinical team to subclinical seizures. When we look at the 4-year outcomes after heart surgery with DHCA or low-flow cardiopulmonary bypass, What you can see is that children had deficits in their full-scale IQ, verbal IQ, performance IQ, as well as possible or definite neurological abnormalities on exam. A study that was carried out at CHOP by Dr. Gaynor and colleagues looked at postoperative EEG seizures, which were actually treated, and 4-year outcomes. Now, this was not just a population of transposition, but a more diverse population. But what we can see over here is that the deficits that we're seeing at 4 years following neonatal surgery, neonatal and infant surgery, I should say, are some deficits in executive function and some restricted and repetitive behaviors. But the issues with cognition, language, and visual skills were not observed in this study, suggesting that treatment of seizures may have resulted in improved 4-year outcomes. Again, 2 different eras of surgery and probably many other confounders, but some data that suggests that this may be an association that's real. So, what would we do in order to figure out whether treating seizures really makes a difference? What we would do is that we would randomize patients who are having subclinical seizures either to treatment or to no treatment. And that's what one group of neonatologists did. They randomized 69 neonates with hypoxic ischemic encephalopathy to treatment of EEG seizures alone or treatment of clinical seizures. And these 50% of these neonates developed seizures. 15 were EEG only, and 20 were subclinical. And the outcomes that they looked at were brain MRI and neurodevelopmental evaluation up to 2 years of age. This graph shows the association of seizure burden and treatment in the electrographic seizure group compared to the clinical seizure group. And what you can see over here is that with treatment of EEG seizures, there was a lower seizure burden. The number of EEG seizures was also significantly lower, and the time to treatment completion was also lower when treatment was initiated for EEG seizures. And how did this correlate with outcome? So with Bailey testing, the cognitive composite score, the motor composite score, as well as the language composite score, was related to the seizure burden. So increasing seizure burden was associated with lower scores in all 3 domains. The lower graph shows MRI brain injury, and increasing seizure burden was associated with increasing MRI injury and severity. So increasing seizure burden was associated with higher brain injury and lower performance in all 3 Bailey domains. So not in our population of babies with congenital heart disease, but in a population of neonates with hypoxic ischemic encephalopathy. So this is really serious, and why aren't we all monitoring patients? So what does EEG monitoring entail? So the first thing is surgeon, intensivist, and neurology buy-in. So I can walk into my ICU today and say that I want to monitor all the babies with EEG, but you need buy-in from the surgeon. The neurologists need to have the capability to interpret these EEGs, as well as enough machines in the hospital to accommodate these patients. You also need to have a technologist that's available 24/7. And these technologists are fantastic. They help us with placing the EEGs, sometimes removing the EEG leads when patients have to go back to the OR, and also do the preliminary interpretation of these EEGs 24/7. The neurologists confirm interpretation, and they notify our team. And then you have to have a seizure action plan with standardized treatment for these patients. Continuous EEG is also very resource intense. So this study looked at the incremental cost-effectiveness ratio of EEG monitoring. On the y-axis, you have the incremental cost-effectiveness ratio. On the x-axis, you have the probability of seizures. And where we're at currently is around 10% of our patients are having postoperative seizures. So if you monitor everyone and you're going to see for 48 hours and you only see 10% seizures, then what you can see is that the ICER is up there around the 75,000 range. However, if you can find and identify a high-risk subgroup with a predicted probability of, say, 40%, whether this is patients with hypoplastic left heart syndrome or underlying brain abnormalities, you are able to monitor fewer patients and therefore decrease the incremental cost-effectiveness ratio. So this was something that I was very interested in doing because I do believe that there are some patients that are at higher risk of seizures than others. A patient who's had a 7-minute bypass run for PA-plasty doesn't necessarily need EEG monitoring. However, what we tried to do was that we developed and validated a prediction model. I believe that we shouldn't just develop it at CHOP, we should incorporate other centers' practice. So there were 2 other centers at the time I started this study that were routinely monitoring babies with postoperative EEG. And so we incorporated their experience into ours. We selected variables from preoperative and operative variables using either logistic regression with backward elimination or with lasso regression, which is a machine learning algorithm in Stata. And given that there was significant intercenter variation in key variables, the model used a combined cohort with a random 70-30 split for derivation and validation. These are the preoperative clinical variables and operative clinical variables that we used for this prediction model. So in prediction modeling, you can throw in whatever you think is important. It doesn't necessarily have to be significantly associated with seizures. It's just things that you think make sense as a potential predictor. So what we found was that the following predictors gave us the best seizure prediction model. Some of these are the risk factors that I've described to you in our previous work. However, when we looked at this seizure prediction model, which had relatively good performance in the derivation cohort, in the validation cohort, the performance was quite poor. And had we implemented this, we would have really missed a lot of patients who were actually having seizures. So we could not identify a high-risk cohort for targeted monitoring. And for now, we recommend monitoring all neonates who have surgery with cardiopulmonary bypass. There are some important predictors that were not included, which included EEG background. We didn't have this information for all the other centers. And then not all centers do routine preoperative neuroimaging like our own center. And I suspect that if these 2 variables had been included, we would have had a much better seizure prediction model. How can we prevent other stresses like cardiopulmonary decompensation? I think prediction analytics with real-time physiologic variables is really going to be what is going to help us really prevent cardiac arrest and decompensation in our patients. This was a beautiful study from Texas Children's where 25 neonates with hypoplastic left heart syndrome were monitored using the SickBay platform. And a prediction model was derived based on physiologic variables that were associated with cardiopulmonary decompensation. So these were unplanned intubations as well as cardiac arrest. The cardiopulmonary deterioration events in this model were identified 1 to 2 hours in advance of overt extremis, and the performance of this model was excellent, with a receiver operating curve statistic of 0.9. A little bit about how our EEG has also predicted cardiac arrest in some patients. 9% of our EEG cohort experienced cardiac arrest in the perioperative period. And in reviewing some of these EEGs that captured cardiac arrest, EEG changes were noticed to precede vital sign changes and altered bedside and the alerts so we're able to actually see on video what's going on at the bedside when patients arrest with the EEG monitoring, because there's a video there. And what we saw was we reviewed the EEGs of a group of neonates, and what we saw was that these patients were having EEG changes in some kids, up to a couple of minutes prior to their cardiac arrest, without heart heart rate changes or without any other kind of activity at the bedside is the best way to describe it. So we hypothesize that cardiovascular decompensation, not surprisingly, causes decreased cerebral perfusion, which causes decreased cerebral activity. And that's why we were seeing these changes, and these are a potential window of opportunity for intervention. So this is a tracing from one of the patients. This is their initial continuous EEG background when they come back from the OR with continuous low voltage. And then what you see over here is that you can see that the background changes to what is called progressive excessive discontinuity, so a little bit more flat over here. And then you see this is immediately prior to the arrest, and the few seconds prior to the arrest, there's low voltage suppression. Notice at this time the heart rate really hasn't changed. And over here you see the heart rate's becoming slower, the EEG remains suppressed, and you can see what's happening with the heart rate, which is all the way at the bottom, and there you see CPR artifact. So EEG background was abnormal in 68% of neonates immediately following cardiac surgery and worsened in 100% several minutes prior to cardiac arrest. The median duration was 3 minutes. These EEG changes may be an early sign of impending cardiac arrest and may predict developing cerebral dysfunction. Identification of EEG changes could allow for interventions to prevent cardiac arrest. So in conclusion, EEG monitoring can detect subclinical seizures in neonates following surgery with cardiopulmonary bypass. Treatment of seizures may improve outcomes, and real-time physiologic data platforms with risk algorithms are really promising for postoperative deterioration. I'd like to acknowledge our neurocardiac critical care group, which is a diverse group that comprises of trainees as well as neurologists, intensivists, cardiac intensivists, and data analytics folks, as well as surgeons, and our collaborators from other centers. Thank you.
Miriam, thank you. It's a very terrific overview of this kind of complicated problem. In particular, I think it's hard for us to wrestle as clinicians. How do you contextualize the subclinical seizure part? And I think one of the interesting findings you mentioned quite a bit back from the study from CHOP was that in those kids, the infants, or in this case probably newborns, who actually had what you would normally press the button for, the actual activity, that there was not a very tight correlation with the seizure activity on EEG. So one question would be, what was that? And was that actually a brain abnormality that was causing that? And the other is what are we doing when we're treating the clinical activity? Are we really suppressing seizures?
So the push-button events were predominantly hypertension. So it's probably that the babies are, just waking up from anesthesia and they were becoming acutely hypotensive. So the most common reasons why the nurses pressed the button was hypertension. The other reasons why there were push-button events were tachycardia and desaturation. And none of those vital sign changes actually correlated with seizures. In terms of suppressing seizures, we actually don't use or routinely don't use any medications that are known to suppress seizures perioperatively at CHOP. So we've intentionally excluded routine use of benzodiazepines, for example, in our perioperative sedation pathways, because we know that benzodiazepines are associated with worse long-term neurodevelopmental outcomes in premature babies. And when you kind of correlate our patients' brains to the brains of, say, 36-weekers, I intentionally left benzos out of our sedation pathway, so in that population. So they typically get fentanyl. So I don't believe that we're actually suppressing seizures. I think the reason why the majority of babies have subclinical seizures is because, so it's twofold. One is that babies don't have very mature myelinated neurological systems, so therefore it's probably more common for them to just have subclinical changes versus overt motor changes when they have seizures. And the second reason is probably that we use paralytic in a decent amount of patients. So because of that, patients aren't able to kind of mount that clinical motor response to seizures that we see in older children and in adults.
And so for, I'm sure a lot of the reception of your study and other studies has been at many other places that's not economically feasible probably to monitor all newborns and or infants who have heart surgery. And so I think one of the challenges from a fiscal responsibility standpoint and also from a just implementation standpoint is who should we monitor if we can't monitor? If we cannot monitor everybody, who should we monitor? And are we monitoring them for the right amount of time? Like, how do we choose the window? Should it be 1 day, 2 days, 3 days? Should it be their entire hospital stay? Are we doing enough for them or are we doing too much?
I'm going to answer the question about duration of monitoring first. So one of the things that I was really interested in looking at was whether we could just monitor babies for 24 hours and then be done with it, because obviously keeping them on an EEG is resource intensive. So unfortunately, seizures occurred in our population at a median of 28 hours after return from the OR. So if we just monitor them for 24 hours, we would be we would be missing some patients, and then up to 36 hours post-operatively, one of the patients actually started seizing at 36 hours, so you would miss some of those patients. In terms of who to monitor, I would say that my answer has changed over time. Initially, it used to be patients who have prolonged deep hypothermic circulatory arrest longer than 40 minutes, which is what Dr. Gaynor found many years ago and what was kind of replicated in our study. But recently, when I've been looking at this more, I think that the hypoplas, the Norwood operation, is one where we definitely see patients seize post-operatively. I think it's about 20 to 25% of Norwoods at our institution have post-operative seizures. And then the other patient is that patient, and Jonathan, you will be able to understand this. It's where things just don't go right, where everything, you have to leave the chest open. The kid is kind of up and down on their blood pressure. You have to take the kid to cath immediately post-operatively because hypoxemic. The kids who have just a really challenging surgery. So as you can see in our prediction model, there was like nitric oxide, which isn't nitric oxide use in the OR, ECMO use in the OR, cardiac arrest in the OR. So it's really those patients, the sickest of patients, that would probably be the patients that I would recommend. However, that being said, I am doing a risk factor analysis that incorporates EEG background variables at CHOP, and also doing a multi-center analysis with more than 1,000 patients now to see what exactly the risk factors are. And so perhaps people who have limited resources can just monitor patients based on those. But I would say that if it was to be one lesion, it would probably be hypoplastic left heart syndrome.
I think some of the maybe most powerful part of your study was our understanding as surgeons how common this is. I mean, I think we each individually, we have our own anecdotal experiences, but when you actually look at the data, I think the cardiologists probably do a good job of this. I don't know if we as surgeons do as good a job at preparing parents for the fact that it's actually a pretty common phenomenon. We definitely warn them about having the EEGs, because that in and of itself, for those who are not as familiar, it's a cumbersome, many leads. They're all connected to the baby next to the bedside. It makes it kind of difficult to do the usual nursing care. Can be challenging for sure. Are you pulling up a picture of this?
I just want to show you a picture of actually one of Dr. Rychek's patients, and we have permission to use all these pictures in our talk. So this is one of Dr. Rychek's patients who had an arch augmentation and PA band, and there he is. This is less than 24 hours post-operatively. So I think I extubated him post-op day 1 morning, in the morning, and then by noon we put a bottle in his mouth. So it does look cumbersome at the bedside, but there the baby is on post-op day 1 feeding. Parents can hold with the EEG monitor. And then kids can also go out to the CCU on EEG monitoring. So, it's definitely more cumbersome and more equipment compared to near-infrared spectroscopy, but, the babies are actually able to do just about everything that they should be able to do on, post-op day 1.
So here's I would normally say it's the $1 million question. It's probably more, many $1 million of questions. which is, and it's a sort of a teleological question. So if we take at base value that seizures are a manifestation of cerebral injury, then by suppressing the subclinical seizures, it makes logical sense, and the outcomes part would sort of match your speculation, although it's not hard outcomes that show that treating the seizures gets you better outcomes. So the teleological question is, are we treating seizures, or by suppressing seizures, are we treating the symptom and not the cause? If the proximate cause is overall cerebral insult, then is that like is it like treating fevers with Tylenol? Not that you shouldn't do it, but just that we're focusing on the clinical manifestation of what is a much more profound central problem.
Right. So seizures are definitely a biomarker of underlying brain injury, and till we do routine pre and post-op imaging with MRI on all our patients, I would say that EEG monitoring is like one of the best ways to stratify our patients post-operatively into who needs neuromonitoring compared to who doesn't. In terms of treating seizures, I think that I've shown you data from the HIE population that seizure burden was actually associated with neurodevelopmental outcomes. So children who seized more and longer, and as I said in the Boston circulatory arrest study, subclinical seizures weren't even treated. Those are all associated with kind of impaired long-term neurodevelopmental outcomes. So I think there is some data, I showed you in vivo data, that shows that seizures increase cerebral metabolic. It kind of makes sense, right? It just, even if we didn't have data for it, if somebody's seizing for a long period of time, their cerebral oxygen consumption is increasing. They already have brain injury. How much do seizures cause, or prolonged seizures? One seizure probably isn't very important, a 10-second seizure. But if a patient's seizing for 10 minutes, 20 minutes, 30 minutes, I think that does cause secondary brain injury. And that's really not what we want in our patients post-operatively.
And are there other technologies that are on the horizon that will be, I would say not better than EEG, but are different from EEG that help us with the predictive analytics? I think the sick bay value is profound, right? What you've noticed, which is that these seizures, reflective of whether it's cerebral injury or cardiopulmonary collapse, whatever that is, they are proximate to that. And so if we can get even further upstream, maybe we can kind of rewrite the ship before things all go awry. Yeah. So are there other technologies that are out there?
So there are a couple of other technologies, and very specifically EEG technologies. So one is called AEEG, which is the neonatologists have been using it for a very long time, and it's just a limited EEG. It's 2 leads that are placed in the frontal area, and the neonatologists have been using this for many years, and they're actually able to interpret the EEG at the bedside, so they don't need they don't need a neurologist to interpret it. They don't need an EEG technologist necessarily to put it on the patient. It's used very, very commonly in Europe. But the problem is that it doesn't necessarily detect seizures that are posteriorly located. So in our patients, seizures can occur anywhere in the brain. And I think a couple of years ago, Dr. Gaynor and colleagues actually looked at AEEG in their patients. So they just looked at those 2 leads that are used for AEG, and they would have actually, if we just did that, we would have missed a lot of seizures in our patients. So other centers do use AEG in patients. In terms of other EEG technologies, I would say that there's another device which has got EEG monitoring as well as near-infrared spectroscopy together, which is a really cool device. But again, it's limited to just the frontal area. So the EEG that we perform is like a full neonatal montage that covers the whole brain. And I just feel that, I'm biased, but I feel that we don't want to miss a seizure anywhere in our patients.
So maybe switching gears a little bit, you've had a very unusual and extremely international upbringing and in your training also. And I'm sort of curious, partly in the context of this, but sort of maybe you can generalize a little bit. how that experience of having lived, trained, provided medical care in these different settings has changed who you are as a physician today. But in particular, in this instance, you're talking about a very high resource-heavy technology that is, it's a luxurious position to be in, to be able to monitor all of the babies that we have in the ICU. So how is that background for you? How has that changed the way you look at things? Does it make you feel, fortunate to be here, or it makes it harder for you to imagine how it can be a therapy or guidelines that we can actually reasonably implement worldwide?
So, so the way I grew up in many different countries, and then from England, ended up going back to Pakistan for medical school because my parents were diplomats, and if I stayed in England for medical school, they would have had to pay a lot of money. So instead, I went back to Pakistan. I also wanted to learn more about Pakistan because I never lived there for a very long period of time. And I got into a very nice, probably what one would call a very elite medical school in Pakistan. But from day one, we were kind of thrown into the slums of Karachi, and I would say that really grounded us. I think that the background that I have, I think that what it brings to the table, at least, is that I don't know how much it affects me in the clinical care I take of people, but just think that growing up where you moved from one country to another, you went to international schools. One thing, I've lived most of my life in the States now, but I would say that one thing that I never saw or learned about were stereotypes. That's the best way to describe it. So I don't put people in boxes. I think I treat everyone the same. I hope that the people I know who have met me see that. So I think that where it really helps me is with my interpersonal connections, not only with the people I work with, but also with the people I meet day to day, my patients, everyone at CHOP who I've known now for almost 20 years. So I think that that's kind of that human connection that you can have with others, from just becoming very resilient, because you move to a place, you make all these friends, and then like 3 years later, you're uprooted to another place and you have to make new friends. So instead of like that being an adverse upbringing, it was like very positive. And so I feel that that's really helped me. In terms of taking or being in a very resource-rich environment, I think that there are things that we can take back to resource-limited settings. And one thing I've tried to do over the last couple of years is go back not only to Pakistan, but also to other developing countries, not only to teach, but also to learn from them. Because when you go to a resource-limited setting, you see that people practice medicine very similarly to the way we do, but they do it with much fewer resources. So, in ECMO, for ECMO, for example, in Pakistan, if a patient goes on ECMO, then it's for a short period of time to, really see if they recover. Say if it's a post-op patient, then like 24, 48 hours of ECMO, and then that's it. And the patients usually come off. So I think that I actually learn more from the resource-limited setting, going back there and bringing that here, because then I'm more ready to like get kids off, therapies quicker, use less resources, order less tests. So I'm not sure if I'm answering your question properly, but hopefully you can understand that I feel that it's a constant knowledge exchange, and I don't feel torn when I go to resource-limited settings. I feel more that I'm learning how I can practice with less. That's the best way to describe it.
You bring that up. I was just telling one of our fellows in the OR the other day, I was encouraging him in his career to go to the developing world, which I certainly have done almost annually, probably since I finished my training. And I said to him, because you're going to walk into an operating room and they're going to have 6 Kelly clamps and a scalpel, and you're going to have to do this whole operation with 6 Kelly clamps and a scalpel. You don't have the 300 instrument set that we have where we talk about we want the reverse angle scissors or the straight angle. You just get a pair of scissors. And I think it makes you a better surgeon. And I wonder whether, I mean, we don't spend that much time there. I don't know how much time you spent in other places, but I would assume, or in these centers that we've talked about, but I would assume it probably makes you a better intensivist too, I would think. But I don't know. Do you feel that when you leave, you're more than just the economics of it, that you're actually a better clinician?
So I haven't really practiced clinically in other settings. I always teach, and the reason for that, I have to say, is that I kind of have had this philosophy that the people, and it's different in surgery compared to medicine, but the cardiac intensivists in China and in Pakistan and in other places are probably better cardiac intensivists than me, because they work. For example, in China, they work with just so many more patients. Their cardiac surgeries, and even the smallest centers are 1,000 more cardiac surgeries than we do a year, and like the smallest center in China that does cardiac surgery. So their clinicians are very, very strong. And so what I try to do is actually not practice when I'm there. I definitely join on rounds, but really try to teach fellows pattern recognition, which is just so important. Teach them a little bit about neuromonitoring in our work, for example, cardiac arrest, cardiac resuscitation. But yeah, I think that it does make me a better intensivist to go there for sure. But in a different way, it just makes me a better teacher, I think, more than anything else.
I'm interested in your comment about growing up, because you moved with diplomat parents. You probably moved every couple of years, right?
Yeah.
Among all these places. And growing up with this notion, I mean, it's very relevant today, obviously, right? The notion of growing up seemingly without bias. But do you find that, now your training was Pakistan for Aga Khan for the medical school, but then what after that?
Then after that, it was the Mayo Clinic for residency, and then CHOP for everything else. So CHOP for critical care and cardiac critical care. And I've been here at CHOP since then.
Yeah, because I think one of the things that is, I think it's a challenge for us. I think we're actually same thing, different fellows, same interoperative conversations of just kind of, sitting around talking about careers and stuff. And I had said that my father used to chide me about, I did all of my training in New York City at Columbia, general surgery, cardiac, congenital, VAD, et cetera, and stayed on faculty there. And he was always chiding me that I'd stayed at one place for so long that I was just becoming, he didn't say this, but he implied that I was becoming closed-minded. And I think that I think a real challenge for all of us is, I mean, we're challenged socially by the bias question, but that can be sort of translated into medicine, into us being challenged by to challenge our own biases that are center-specific. Your data from 2012 to 2015 had almost exclusively deep hypothermic circulatory arrest, which is something that we do a lot here, have historically done a lot here, but that's not necessarily the case around the world. And so I wonder whether you feel as though your upbringing and to some extent your training has influenced more so than other people you work with or other colleagues around the world, your open-mindedness to other ways of doing things. Because I mean, I think that's the challenge, right? How can you be appropriately critical of new ideas, but at the same time try to incorporate things or you cease to evolve, right?
Yeah. So one thing I've always had is a love of learning, and I really do believe that, there's not one way of doing things. So if you look at our ICU team, the cardiac intensivists are not all CHOP trained people. They're people who have come from other centers, and I think that the way that we help our patients best, not just as a cardiac ICU team, but as a cardiac center team, is by groupthink. So, one of the reasons I love working at CHOP is that in the middle of the night when I'm stuck with a patient who is, I'm scratching my head and I know that something bad's gonna happen, but I don't know why it's gonna happen. You just have that gut feeling. I have, you or Jack or so many others that I can just call and be like, can I just run this by you? I've been doing this for 12 years as an attending. And, I think you always have to bring humility to the bedside when taking care of our patients. And maybe that is something that comes from my upbringing, which is, I really do believe in other people's opinions. I think just working in the cardiac ICU, you're a good cardiac intensivist if you know who to call when you're in trouble. I'm sure that my upbringing has something to do with it, but I also know that like many of the really good doctors I know always ask for others' opinions and don't have one way of thinking about something. When it came to the seizure prediction model, which was my master's thesis, I initially thought, well, why not just develop this at CHOP because it's going to work really, really well at CHOP. But just as you said, we weren't doing antegrade cerebral perfusion at CHOP. We had these really fast bypass times because we used deep hypothermic circulatory arrest. So when I compared what we did to what other people have published, I was like, I'm going to develop a seizure prediction model here, and it may work beautifully at CHOP, but like, how is anyone else going to be able to take it to their center? Which is why I solicited, even though there weren't a lot of patients, we got data from other centers that were routinely monitoring patients, and those centers did have longer bypass times, and they did use antegrade cerebral perfusion. They did have more patients who had an open chest after neonatal surgery. And so I think that just made my work and my prediction model better because I may have been able to publish something that looked fantastic, but nobody else in the country would have been able to use it. They can't as yet because it doesn't validate well, but maybe in the future we'll have something better.
Well, I think your concept of national and international collaboration is key. I don't know, the sort of platonic dream of the prospective randomized trial is so difficult to implement. No more, probably even the pinnacle of that would be to try to do this in something like seizure monitoring because the practices are so variable and no one wants to be in the control arm of that, I would assume. Have you ever thought about that? Like whether there's any possibility of having, we have so few in our field to begin with, but whether this would ever be a candidate for that kind of study?
So I would just, I would kind of throw that back to you. I would not have equipoise because I, strongly believe that seizures, especially prolonged seizures, can cause brain injury. But, as a cardiac surgeon, what would you, do you think that your kind of community would have equipoise if we decided to do a randomized trial of, monitoring everyone and just treating some patients who have subclinical seizures and not treating others? Do you think that the cardiac surgeons would have equipoise?
It's a good question. I don't know. I will say I've been impressed in the last several years in our national meetings that there has been more, and it might be a evolution thing, it might be a generation thing, that there's been less religion and a little bit more science and a little bit more equipoise, in particular for the perplexing conundrums that we're just tired of talking about. And one of the most recent ones in the last year has been BT shunt versus ductal stent versus some sort of RV outflow tract thing. Every single meeting for the last 10 years has had some debate or whatever on this, and we never come to a conclusion. And I think people are just fatigued. They're fatigued with these inconclusive studies that you just can't compare the apples and oranges. And so people are almost fatigued to the point that they'll say, it's sort of like fatigue has overlapped with equipoise. And we say, you know what, uncle, we'll do the study. We'll randomize, and because we don't know. And so back to your idea, I think, of humility, it's understanding and knowing that you don't know what you don't know, that maybe will force us into that. I don't know. I think it depends. I don't know how many cardiac surgeons are so religious about knowing that treating seizures matters or doesn't matter. It might be a hard sell to parents, to be honest, to enroll in that.
So when I presented these data at AATS, I think I want to say it was 2013, maybe for the first time. I was in one of the congenital sessions, and Bill Gaynor had told me there's just going to be, you'll get a couple of questions, but it'll be fine. You'll be able to answer everything. And then I finished my talk, and 19 of your colleagues kind of, stood in a row behind the microphone, and I would say there were lots of questions, so very similar to the questions that you asked me about whether seizures were, and at that time we didn't know whether there were any data to support the seizures are causing worse outcome, what the cost of monitoring patients was. There were lots and lots of questions. So, yes, maybe we will have equipoise. We certainly had equipoise randomizing patients with hypoplastic left heart syndrome to the Norwood versus the BT shunt, or at least group equipoise for that. So this would definitely be something, it would be very, very interesting to do a randomized study. But the current problem is that the technology that we have here at CHOP is really not available at other centers, and there are many other indications for patients to undergo routine EEG monitoring that those patients would probably be prioritized over ours. So hopefully in the future, where we can come up with less expensive technology or more widespread technology and be able to randomize patients.
Well, with that, I will thank you, Miriam. Fantastic talk, very provocative. I hope we can find the right study and the right patients to kind of answer those questions.
Thank you.
And to all of you, thank you again for joining us for Pediatric and Congenital Heart Talk. And now back to you, Jack Rychik.
And thank you all for your attention and for listening to this fantastic talk and life lessons and life advice. We are very much interested in your feedback, and we'd love to hear questions concerning our content that you've heard, as well as suggestions for additional topics that would be of interest to have reviewed in depth and discussed. In order to communicate with us, we have a dedicated email address. It's chophearttalks@email.chop.edu. We'd appreciate hearing from you. We'd love to hear your ideas and suggestions. Thanks so much for your attention.